Everyone so much for coming today for our Insight to Impact second module. We're really lucky to be really lucky to be joined by Robin Urquhart. Robin's an associate professor and Canadian Cancer Society endowed chair in population cancer research in the Department of Community Health and Epidemiology, with cross appointment in the Department of Surgery and Division of Medical Education at Dalhousie University. She's a senior scientist with Beatrice Hunter Cancer Research Institute and an affiliate scientist at Nova Scotia Health. Her research largely focuses on issues related to access, quality of, and inequities in cancer care. She also leads a large research program to identify the causes of cancer and therefore improve cancer prevention and early detection. So thank you so much, Robin, for being here today. We're so lucky to have you. And with that being said, I will hand it over to you.
Okay, fantastic. Thank you very much. It's a pleasure to be here today. Especially, I know folks are coming in from all over, but I'm in beautiful Halifax today on the East Coast, and it's nice and sunny here. So if there's a problem, Erin, just with my slides, just let me know throughout. That's easy. So I'm going to talk today about signs, symptoms, and risk cancer, and risk factors for cancer, for pancreatic cancer. I do want to acknowledge where I am in this beautiful part of Canada before we get started. So I had just said sort of Halifax, which really has been known as Mi'kma'ki for time immemorial. So I live and work here. I'm at Dalhousie University, and of course, this is the ancestral, unceded, and unsurrendered territory of the Mi'kmaq people. And this is a photo of Kejimkujik Lake. If anyone knows the East Coast at all, it is a lake in the middle of Nova Scotia that that certainly has a lot of significance and importance to the First Nations here in Mi'kmaq, but also, just to me and my family. So I'm not from Nova Scotia, and I'll talk about that in a little bit, but I've been here for a very long time. And so this is a lake in central Nova Scotia that has, that's a beautiful place to sort of camp in the summer and spend some quiet time. I also recognize the histories, contributions, and legacies of the African Nova Scotian people who have lived here in Mi'kma'ki for more than 400 years. So today, 3 learning outcomes. One is to understand key risk factors for pancreatic cancer, including familial history and genetic predisposition, to sort of be able to identify and describe common signs and symptoms of pancreatic cancer, and really to learn the importance of early detection. And we can have a conversation around when to maybe seek medical advice. So I should say, off the top, I'm not an MD, so that would have been, I'm a PhD trained researcher in the cancer field, and so yeah, so just so that we know that up front. But I do a lot of work in risk factors and early detection of cancer. I'm going to put this up just to sort of contextualize myself and where I come from, especially when it comes to pancreatic cancer. I was born in a tiny town in Newfoundland and Labrador, in the White Bay. So a small town. When I was growing up, there were about maybe close to 500 people who lived in the town. And today, probably a little over 100 people. And it may be hard to see here, but it's a rural area of the province. And there's a picture of me and my cousins at a birthday party when I think it was my cousin's birthday. She was turning 1, and I'm the person chewing on the red balloon there. This was in my grandparents' house. And I bring this up because I grew up in a very sort of, family-oriented community where, we just sort of played and went about our lives and enjoyed life. And then in this community, as I was growing up, there was quite a few people who developed cancer. Many of them died. Access to care, which is probably why I've always been interested in access to care, was kind of sparse. So the nearest sort of cancer center was 7 hours away, and that was on a good day without snow, on good roads and so on in St. John's. And so here's a picture of my parents. So then as I was growing up, had a great childhood, young childhood. And then when I was about maybe 10 years old, my dad got really sick. Didn't know what was going on, had a lot of the signs and symptoms that we'll talk about later. Was sick for probably a good year or so, back and forth, having to go back and forth to St. John's, Newfoundland. So 7-hour drive, again, on a good day. And yeah, wasn't sure, had, at some point had developed jaundice, had a lot of weight loss, had incredible back pain, and we'll go through all of those signs and symptoms later. And then was diagnosed um, so this was over the span of a few years in his 30s, and then was as diagnosed and died, diagnosed when he was 38, and then died a few months later of pancreatic cancer. So at the time I was 11 years old. He died about 1 week actually after I turned 11. And then 3.5 years later, my mom got quite sick. I was 14 at the time, and went in, had quite sick, nausea and vomiting for a long time, again, weight loss, and ended up into emergency surgery. And people came and got me at my school and brought me sort of to the hospital, which was an hours and hours drive away, again, just to tell me she had pancreatic cancer. And so she was diagnosed when she was 34 and she died when she was 35. So I bring all of this up because I think that um, I'm quite passionate about pancreas cancer, but I also sort of understand how important it is to detect cancer early and to detect pancreatic cancer early, and how important it is for people to understand the signs and symptoms of pancreas cancer. But I also can reflect back and think about all of the all of the opportunities right now. So what was available at that time versus today, and if someone is diagnosed, and there are a lot more opportunities. Many of them are research opportunities, but we're learning a lot more about pancreas cancer. And I just want to highlight one sort of study or one opportunity at the end of this. But I think the other part, if there are family members here of someone who has had pancreatic cancer, I think the other part about it is, like I said, both my parents, my dad died when he was 38, my mom died when she was 35. So, I have kids that are here today and they've been told not to interrupt me. But, for a long time, particularly in my 30s, had a lot of anxiety. Like so I know what that feels like. Like I really never thought I'd see 40, right? So when I turned 40, it was just like, it was almost like I had a different life. I really didn't think I would get there. So again, that anxiety and that sort of was really, really a big part of my 30s in particular. So I'm going to switch from talking about, my own living experience with my parents having pancreatic cancer, again, a long time ago, and sort of talk about today. So you may have seen this, or this may have been, at some point, these are a map of the world from 2020, just looking at incidence rates, age standardized incidence rates of pancreas cancer. So really all I wanted to point out here was the highest incidence rates are really in North America, Russia, Northern Europe, Australia. So in more of the developed, for the most part, developed countries, high income countries. And that's like a lot of the increase we see is because of aging. And so I'm going to talk about that in a minute, but also these are age standardized rates. So it's not only because of aging. There are other factors that are contributing to these high rates of pancreas cancer. There are other risk factors. So I want to talk about risk factors for a minute. You might see me keep looking at my my phone every now and then, not because I'm expecting a text, but I'm just looking at time here because I don't want to go over. Um, and so I think when I think about risk factors, again, I study risk factors, cancer risk. And so when I think about them, I think about things we can't change and things we can change. And I say theoretically there, and there's a reason why I say this, um, because sometimes changing things can be really difficult, right? And so it's not always at an individual level that we can change. Sometimes it means there has to be policy change, like something has to change, but it can change so that, we can reduce our risk. So the first thing is age, or things we cannot change: age, our sex, and our race and ethnicity. And so age is one of the strongest risk factors for pancreatic cancer. Almost all patients are really over the age of 45, but not all. I just talked about my parents. They were both in their 30s. So it's not, it's not all. But really being over 65 years of age. So about 2/3 of all of pancreatic cancers are in people over 65 years of age. We can't change that. um, and that just happens partly because as we grow older, we become, we have longer exposures to different types of things in our environment. And by environment, I don't just mean like, you know, chemicals at the workplace or something, but, tobacco or sort of decades of being overweight and things like that, that sort of just damage our DNA, damage sort of our at the cellular level. And over time, that sort of enough damage happens that we start to develop cancer. The other thing we can't change is sex, the sex we were born with. Not, so I'm talking about biological sex here and really not gender. But really incidence rates for males are somewhat higher than for females, especially in people who are younger. But we don't really know a lot around why that is. And I think there's a lot more research that needs to be done to help us understand that. The other thing we know is that pancreatic cancer is higher in certain countries and in certain sort of ethnic groups. So here in Canada, Black Canadians will have a higher risk of developing pancreatic cancer. They get pancreatic cancer more often. Also, sort of some individuals of certain Jewish ancestry have a higher risk of pancreatic cancer as well than people of other ancestries. We need research to understand why that is. We don't know a whole lot about that yet. And then there are things that we can change. So we often call these modifiable risk factors. I don't love that term because sometimes I feel like we think that the individual can modify them. And sometimes it's very difficult to modify these things. Even, if you look at something like diabetes, well, it's very easy for me to sit here and say, well, you can change that. Well, maybe the individual can't, but as a population and as communities, we can change our rates of diabetes. So things we can change, tobacco use. So smoking, tobacco use is a very well-established risk factor for pancreatic cancer. And I do a lot of work in lung cancer. I'm actually quite passionate also about lung cancer. And there's a big stigma associated with tobacco use and smoking. And so when I talk about this, I don't want to propagate that in any way. It's, for decades, for decades, people with lung cancer have been told that, they did it to themselves or they feel like they did it to themselves. Well, tobacco companies have been pretty smart and they've put a lot of things in those cigarettes to help to keep people smoking for a very long time. And we know that now, right? So tobacco use, again, very well established. We know that quitting smoking, just like in lung cancer, for pancreas cancer, will also reduce your risk over time. And so the risk of pancreatic cancer, if you've been, if you've smoked and then you've quit smoking, the risk of pancreatic cancer will decrease such that by 10 to 20 years after you've stopped smoking, your risk is really not that much different from a tobacco risk as a never smoker. So you can reduce that risk. The other is being overweight. Individuals who are overweight are at a higher risk for pancreatic cancer than people who are normal weight. Um, and obesity or being overweight is associated with a lot of different cancers, actually. And that's something that many scientists are actually studying really intently right now, because if we can understand that mechanism, we can try to prevent cancers or more cancers, right? And for sure, we're seeing increases in pancreatic cancer in many developed countries, not only because we're aging, but because of rates of being overweight and obese. So diabetes. So if somebody has long-term diabetes, they've had diabetes for a long time, they also have an increased risk of developing pancreas cancer. And it's interesting, people with new onset diabetes are also at an increased risk of being diagnosed for pancreatic cancer. But the interesting thing is that it's almost like diabetes is a risk factor for pancreas cancer, but it also can be like a consequence of getting pancreatic cancer. So you can develop diabetes because you have pancreas cancer and because of that damage that's happening in the pancreas. But anyway, and we often tell people if you have a really new onset diabetes and with other risk factors as well that are involved, that and maybe some signs or symptoms, that you really should sort of be checked. Chronic pancreatitis, if you've got chronic inflammation of your pancreas for whatever reason, there can be genetic reasons for this, could also be sort of, lifestyle reasons. Essentially, that inflammation and the damage that happens at the cellular level can lead to development of pancreas cancer. And then areas that are unclear or where we need some more research. So I'm a researcher, so I'm going to say, there's like sometimes it seems like we have a lot of research in one area, but some of that research is not well done, or we have this emerging researcher, and often you'll talk to a researcher who'll kind of feel like they can never say for sure something causes something, just because there's uncertainty in the evidence. But anyway, alcohol use. So you might read in different places that alcohol use is associated with pancreas cancer, and then you might Google and go on another site and it says it's not. The reality is, there's probably needs to be more research in this, but the evidence that's growing and that's been put out there for the last decade, 2 decades, is really showing us that heavy alcohol use is associated or likely associated with pancreatic cancer. So we're talking about heavy use compared to like little or no use. So not so much moderate drinking, I guess, or moderate use, more in the realm of having like 6 or more drinks per day, up to 9 drinks per day, things like that, very heavy alcohol use. Um, but we need more evidence. Perhaps it is at the lower levels. This is why we don't for sure know. Perhaps it is at lower levels, but we don't have that evidence because our data are not great. Yeah, yeah. Um, Diet. So there is, again, sort of evidence out there that diets high in red and processed meats, saturated fats, also some stuff around sugary drinks now may increase your risk of pancreas cancer. More research needed. Physical activity or inactivity, same story. I would say there's less evidence out there. Well, there is less evidence than diet and alcohol, but it's starting to emerge that lack of physical activity, what we would call sedentary behavior, might increase pancreatic cancer risk. And then you've got some very specific things like certain infections. So H. pylori, which is a bacteria in the gut, which often causes ulcers. And then hepatitis B, which is a virus, which impacts the liver. Those, having those infections again might increase your risk. And then environmental causes. So I do a lot of work around environmental causes of cancer, actually. Again, more in the lung space. But a number of studies, I shouldn't say a lot, I guess it's all relative. A number of studies have looked at the relationship between different things we kind of were exposed to in our environments, often through work, actually, for these anyway, and the risk of pancreas cancer. And there's inconsistent findings, but there are things like pesticides, benzene, and so on, where studies have found that people who are more regularly exposed to those exposures or to those chemicals are more likely to have pancreas cancer. Again, a lot of these are in your workplace. It could be in a manufacturing industry, in sort of dry cleaning, in agriculture, in different things. Okay, so I want to talk about family history and sort of inherited, I guess, risk. So we know through research that first-degree relatives of people who have of people with familial pancreatic cancer. So first-degree relatives, how I'm defining that is at least 2 close family members have had pancreatic cancer, have about a 7-fold increased risk of pancreas cancer. I'm using that term. Different studies will give you different numbers, but essentially there's a higher risk, and it's quite a bit higher, right? So this would be, yeah. So again, sort of people with familial cancer, at least 2 close family members. We also know that pancreatic cancer, if it's in families and seems to run in families, actually clusters with other cancers. So you often see a lot of breast, ovarian, melanoma, prostate, colon, liver, bile duct, and so on. And I think this is important because, again, if we're thinking about, it's interesting, right? Because we've learned so much over the last 15 years, and I will get into that. But this clustering could be related to environment. We could be exposed to similar things, like families that live in the same area, exposed to similar things, and so on. But also genetic predisposition. And so the reality is, it could be in a lot of cases a little bit of both. So one of the things, I have a lot of colleagues who study gene environment interactions. So really understanding how your genetics plus what you're exposed to leads to the development of cancer. Um, in any case, the proportion of pancreatic cancers that are due to sort of some inherited like genetic factor is higher now. It's grown higher in the last, say, decade than we thought it was before, but it could be sort of 20% even higher. So there's something heritable going on. There's something genetic going on. We just might not know what that is. So as we talk about this, I sort of want to sort of bring up, this idea when we think about inherited risk. So I'm going to talk about some inherited genes, gene mutations in a minute. But really all I'm talking about is, genes are parts of DNA that essentially contain, so the DNA is like the instruction manual for how our bodies work, right? It sort of lays it all out there. This is how our bodies will work. This is how we'll function, and so on. Genes are parts of the DNA that really contain the specific recipes for how certain parts of our body will develop and how it'll function. So what happens from a cancer perspective, not just pancreas, what happens from cancer is that those genes get damaged. We call them mutations, gene mutations. Those genes are damaged for some reason, and that can lead this normal cells and their functioning, their development, to sort of grow out of control or to function abnormally, and therefore they become cancerous. So that's how cancer happens. It's essentially damage to our DNA, which over time may damage or mutate our genes, and normal cell growth changes and becomes, leads to cancer. And so, wait, now I'll say, and so there are different ways that we can have gene mutations. One of them is, we call them inherited gene mutations. They pass down through our family. We get them from our parents. And that's what I'm going to talk about here. The other kind of set, we call them acquired gene mutations. You'll see them in the literature. Sometimes they're called somatic, sometimes they're called sporadic, but essentially you didn't inherit them. And what's happened is, over your lifetime, you've been exposed to things that damage your DNA, like tobacco, right? That's one example. And it damages your DNA, and you get these mutations that happen sporadically or, not inherited. So what's happened is, just look at my time. Over the last 15 years, we've had really good advances in technology. I'm going to say right now, it blows my mind when I think about what we can do from a technological perspective and understanding cancer and the cells and so on right now. And so what's happened is, we've got a lot better sort of knowledge and technology. So we've been able to identify mutations, specific changes in a person's gene, and sort of name those and identify them. That's associated with an increase, that puts you at an increased cancer risk if you have them. So for pancreas cancer, I'm not going to go through, I'm not a cell biologist, I'm not a geneticist. I'm not going to go through these, but I'm just going to name them because you might have heard about them. And so some of the inherited gene mutations that we know about right now and that have been identified that would put you at a higher risk of pancreas cancer are written here and sort of on the next slide. So one of them, for example, is a hereditary breast and ovarian cancer syndrome. So you might have heard of BRCA1 or BRCA2. And when we think about BRCA, we think about breast and ovarian cancer. But the reality is, a mutation in BRCA1 or 2 also puts you at an increased risk for pancreas cancer. Lynch syndrome. So this is, there's a number of genes related here, and these are all genes that are related to DNA repair. And so they're called mismatched DNA repair genes. So if you have Lynch syndrome in your family, you are at an increased risk of pancreas cancer, as well as colon cancer and other cancers. And you can see there are others here. Again, I'm not going to go through them. And then on the next slide, here continued. There are still more. So now we've got a number of genes, largely speaking, a number of genes that researchers have identified that put people at, if you have these in your family and they're passed down, they're all inherited, that put you at an increased risk for pancreas cancer. So when my parents were diagnosed, we didn't know about any of this. We didn't have the technology to know about it, right? Like, yeah, anyway, lots of less knowledge at that point, but we knew there was probably something happening, right? Because I should say I grew up in rural Newfoundland. My parents weren't the first people we in my family to have pancreas cancer. I had an aunt and I had an uncle, a great uncle, when I was growing up in this small community, and my parents were distant cousins. It was rural Newfoundland, way back in the 70s, very isolated. So there may have been a genetic component. I mean, there probably is, right? But we didn't know that. Or there may have been an environmental component. Again, families share the same environment, and so you don't know. Um, but it's important, but so it boggles my mind because we know about these genes now and these gene mutations, but those gene mutations probably that we know about and I've identified here probably only explain about a quarter of the heredited pancreatic cancers that happen. That means about 75% we still need to discover those for 75% of sort of pancreas cancers that are hereditary. We still have to figure out what gene mutation, what's happening, like why does this person have, familial or hereditary pancreas cancer. But the reason this is very important, I'll put this up here, is because if you know you or your family has a specific gene mutation, then understanding that specific mutation today, in today's world, can help guide treatment decisions if someone's been diagnosed with pancreas cancer. But it also can prompt sort of early detection and decisions around surveillance or screening, getting different tests and investigations if you've not been diagnosed. So it's really important to know if you're at higher risk, um, because that can change your behaviors around your conversations with your healthcare provider, and then maybe like behaviors around detection, early detection, screening, but also in this like era, we call it precision medicine. So precision oncology, precision medicine. And in this era of understanding that cancers develop because of certain mutations, we're able to develop treatments that target those mutations. And so it's a whole different era than 30 years ago or whenever, when my parents were diagnosed. And so that can help with treatment. Um, okay, so signs and symptoms of pancreatic cancer. So the unfortunate thing is that early pancreatic cancers often don't have a lot of signs and symptoms. And so the pancreas is really deep in the abdomen, in the belly. And we often don't have signs or symptoms until that cancer has at least gotten bigger or spread somewhat, right? Maybe not spread outside the pancreas, but spread inside the pancreas. And then when we start to get symptoms, a lot of the times they're sort of vague and not specific. We would call them not specific, but abdominal pain or indigestion, and that could be a lot of different things, right? And they can come and go and so on. So it's very hard in that sense to detect pancreas cancer early. Having said that, here are a list of symptoms that are sort of common in individuals who sort of present with pancreas cancer. One is weight loss and appetite. So unintended, I guess, weight loss, or sort of a sudden weight loss. You don't know why you're losing weight. And it's unintended. It's very common in people who are then diagnosed with pancreas cancer. They often have little appetite, don't feel like they want to eat, or so on. Um, yeah, yeah. I just want to say that, but if you have weight loss, that certainly doesn't mean pancreas cancer is probably what you have. All of these symptoms, they're at the level where there are very common reasons to sort of have these symptoms. And so it doesn't mean that you do, but we'll get into that in a little bit. Um, Jaundice. So very classic symptom of pancreas cancer would be jaundice. And so a yellowing of the eyes or skin. A lot of people think about jaundice in the context of newborns, right? Many newborns are jaundice, and so they have a few days of treatment to sort of get past that and allowed to get home after they're born. Um, but essentially, jaundice is caused because you have a buildup of this um, thing. I don't know. I don't know if I should call it thing. This substance called bilirubin. And it's bilirubin is just like this sort of yellow brown substance that's made in the liver, and then the liver will release it into our bile duct, so into a duct, and then that bilirubin is supposed to go into our intestines and it'll break down fats that we eat. So it's a part of digestion. Essentially, it helps our body digest foods. Well, what happens is, and then it eventually just leaves our body the same way most things leave our body. We use the washroom and it goes. And so in a normal process, it's like, again, liver produces it, goes through your bile duct, goes into your intestines to break down fat, and then you just let it go in the end into the toilet. What happens with pancreas cancer is that essentially the cancer gets bigger and bigger and starts to sort of block the bile duct. And so it gets blocked. This bilirubin sort of gets blocked. It can't reach the intestines, and then it just builds up and builds up and builds up, and you get this yellowing of the eyes and skin. But I think it's really important for people to know that that's not the other only signs of jaundice. So we often think yellowing, but also if you have sometimes the first sort of sign of jaundice is actually darker urine. And so again, it's like as the bilirubin levels in the blood go up and up and up, the urine becomes more brown and brown, and so you see that sign. So your skin might not look different, but your urine does. The other is sort of so it's actually bilirubin that helps give your stools that brown color. So what if the bile duct is blocked? What might happen is that the stools just become lighter colored, they become gray, they might become greasier. And so again, you're sort of having changes in your stool, which would suggest jaundice or bilirubin's blocked. And the other thing's itchy skin. So when bilirubin builds up in your skin, it can start to itch and start to turn yellow. It can start to itch. So I bring this up because we often think, yellowing of the eyes and skin, but there's actually other signs that bilirubin is sort of blocked and building up in your blood and in your body. Fatigue. So, really, really high levels of fatigue. And this is such a general symptom, right? But just a lack of energy, and it's not related because you didn't go out and run half a marathon yesterday and now you're really tired. It's sort of this ongoing fatigue. The other thing, abdominal and back pain. So, oh, I think I moved something then. Oh, abdominal and back pain, especially in the middle of the back. So it's common. Again, this is just the cancer is growing, and it's pressing on other organs or nerves that is surrounding, and it's causing pain. Again, I had said sort of back to my parents, my dad had incredible back pain, and that was the one thing, and he just couldn't get rid of it throughout sort of all of his investigations, tests, and so on. Weight loss, back pain, fatigue, and eventually jaundice. General digestive problems, again, poor appetite, but lack of um, nausea and vomiting, and lack of sorry, what am I trying to say? Oh, indigestion, bloating, yeah, just general digestive problems. Um, Diabetes again, interestingly, I had said, diabetes can be a risk factor, but pancreatic cancer can also cause diabetes. And that's because the tumor itself, the cancer itself, is actually like just damaging the cells in the pancreas. And so they're not making insulin in the same way as they did before. Um, and so that's sort of a sign or a symptom, like a new onset diabetes. Blood clots, so swelling of your legs, but blood clots often for many people, that's sort of one of the initial, they end up in the emergency room or something like that for a blood clot. And they're being investigated, and it's found out that they have pancreas cancer. Okay, so I'm just about done here. So what if you have risk factors or you have signs or symptoms? So I'm going to talk about risk factors first. So again, pancreas cancer is are hard to diagnose. So that I think that's why it's really important to understand risk alongside of then if you're developing symptoms and so on. So we talked about all of those different risk factors. Some you can change, some you can't change. I think I would again go to if you feel if you've got these different clusters of cancers and you've got pancreas cancer in your family, it probably I would suggest it's worth having a conversation with your healthcare providers because if you don't know if there's something genetic happening or if there's a gene mutation, I think it's really worth having a referral to genetic testing or a genetic counselor, I should say, a genetic service who can then determine whether you should be tested or not. Um, because I think knowledge is power, and it's really important to know for yourself and for family members if there's like a genetic syndrome or there's some inheritable risk, because more and more research is out there trying to understand how we can better detect these cancers early in people who have higher risk, known higher risk. And so then you can make decisions, right? If you know, you can make decisions. Signs or symptoms. So I just want to touch on jaundice. Jaundice is a very serious symptom. Just if you were to have jaundice, it does not mean you have pancreas cancer, but it probably means there's something kind of serious going on because your bile duct is being blocked or because you may have some liver issue. And so if you feel you have jaundice and you can't get in to see your family doctor or your primary care team, you might want to think about emergency room and things like that because jaundice is serious. It doesn't mean pancreas cancer, but it is a common sign of pancreas cancer and it is serious. I also think if you have unexplained noticeable weight loss and you have some of these other symptoms, digestive symptoms, really bad back pain, like that don't go away or they get worse, and we often say about 2 weeks or so, um, if it's just not going away and you have this weight loss, if you have some jaundice as well, again, you need to be bringing these things up with your healthcare team because it's like the cluster of symptoms, right? So if you have indigestion, it could be many, 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 many different things. But if you start to get a cluster of symptoms, then you want to be tested. You want to get tests and referrals, and you want to be, we call it, worked up, because it may be pancreas cancer, but maybe something else, and you need to be able to manage that. So what about regular screening? So I think you probably understand and know there's no routine screening test for pancreas cancer for sort of average risk people. We haven't gotten there yet. Like there is, for example, in colorectal cancer, there's a FIT test, or in breast cancer, there's a mammogram that doesn't exist in pancreas cancer. Um, I would say that here in Canada, so I'm going to speak to Canada because the US has sort of different programs and so on, and depending on where you are, in Canada, you may receive tests and investigations. I don't know if we call it screening per se, but tests and investigations if you do have a strong family history or a known genetic syndrome. But I will say that's going to vary probably across, depending on who your physician or your healthcare team is, but also across provinces. Um, but there are studies that are happening across the country and in other parts of the world where there's essentially early detection and screening studies. And if you have a strong family history or a known like genetic mutation, you may be eligible to take part in those studies. And I think those are really important because um, we're advancing in this area quite a bit. Like it's not like it was, there's still the survival rates for pancreas cancer are still quite poor. I mean, I know that, but our knowledge is like increasing so quickly in this field, like so quickly, like at the level of sort of biomarkers and that sort of thing that taking part in research, I think right now in this area, if you do have sort of a strong family history and so on, is important, can be really important to yourself, but also it's really important for like 10 years from now when we might have a test, right? That can detect. So I always think of the importance of research. I think it can be important for a person and a family, but also very important for future folks who again might, who would benefit from it. So this is my last slide. I just want to tell you guys about an example. There is a term research program out of UHN, University Health Network in Toronto. It's run by an incredible colleague of mine, one of the smartest people I know. And he runs a program or co-runs a program in hereditary cancers in out of Ontario. And so this CHARM research program, it stands for cfDNA, cell-free DNA in hereditary cancers, essentially, in high-risk cancers. So essentially, cfDNA, cell-free DNA, is just they're short pieces of DNA that are just go out in your blood, that just circulate in your blood freely. And most of that cell-free DNA comes from normal healthy cells, just sort of gets just put out there and it's just circulating all over. But cancer cells also release this DNA, but it looks different from DNA, cell-free DNA from healthy cells, so we can detect it. So this is all new knowledge. Like we've just been learning about this over the past years, right? We didn't know this 30 years ago. And so colleagues of mine have developed, and lots of people are working on this, but colleagues out of Toronto have developed a blood test where they can actually detect cell-free DNA from cancer cells. And they're doing this in people who have sort of are a higher risk of cancer because of different gene mutations that they have. And so right now they've developed a test and they're evaluating it in a trial. And so it's happening in Newfoundland and Labrador, Nova Scotia, Quebec, Ontario, and BC right now. So those are the 5 provinces, and it's probably going to extend further than that. But essentially, if you have a known high-risk cancer gene, and that includes the BRCAs that I talked about, that includes Lynch syndrome, that includes some of the others that were on the list here, then you're eligible to take part in this study. And essentially, you get blood tests regularly to see if they pick up this cell-free DNA or this development of cancer long before you'd ever see it on an MRI, right? Or an ultrasound before you'd see it in imaging. And then they'll look at outcomes from that. This is just one example. I'm not involved in it. I'm just trying to like share the fact that there's some really, really good research going on right now, and we're learning so much. And to me, this is fascinating because um, I think there's a lot of hope right now that didn't exist 30 years ago and probably didn't exist 10 years ago. And I think we're going to learn a lot over the next decade because of colleagues of mine like this group and other groups that are really sort of trying to understand whether there are markers in our blood, it could be in our body, essentially somewhere, that can give us that early warning sign that, oh my goodness, a cancer is developing. So now we've got to find it and remove it and treat it. Sorry, Erin, I probably took too long. I just wanted to give that example. So thank you very much. I'm happy in the time that we have left to answer any questions. There's my email. I'm also happy to sort of talk to anyone over email or jump on a call at any point.
Oh my gosh, Robin, no, that wasn't too long at all. That was amazing. That was so good. And thank you so much for sharing also your personal relation to it. I mean, I can see why you're so passionate about it. And that was a really, really wonderful presentation. So thank you so much. We'll now open up the floor too. If anyone has any questions, feel free to either put them in the chat or to unmute yourself and ask.
Would you like me to stop my sharing just so we can see?
Sure. Yeah, if you want to. Yeah.
It's okay. Yeah.
Yeah, everybody.
So, so it's a tough place to be, right? Because pancreas cancer does spread quickly, often, and I think part of it is, it's going to sound funny. I think part of it is a shared decision between yourself and your healthcare team. Because some people with very like frequent ongoing monitoring, um, it creates like a huge amount of anxiety, right? And so maybe people do want to step back short a little bit, but I think over at least the near term for you, near term, I don't know what your health team has said, but over, 2 to 3 years or so, once you've sort of been treated, it probably is it's a good idea to do regular monitoring. The problem is we don't have great monitoring technology, just like you said. Like there's a blood test, isn't great, and then there's an imaging modality that is pretty good, but the cancer has to get so big before you see it, right? And so there isn't. Now I do have colleagues, but it's all still experimental and research related. So I do have colleagues who are trying to look at, again, markers in the blood. One of them are called extracellular vesicles, EVs, we call them, which is funny in this environment because they're not vehicle, yeah, non-gas powered vehicles. EVs that they've been looking at for a long time to see if they can, if again, you can sort of, but again, they're still in the research context, but if you can detect that a cancer has started to grow again or has started to progress earlier using blood test than using imaging. So that work's being done, but it's still all sort of in a research, like in a research context. You could talk to your team and see if they know of any like research studies even. And I say that I know research, I get it. Like research takes up more time then. Sometimes it means you need to travel more and you don't want to because of tests or whatever. But having said that, you know, sometimes some of these studies that are happening right now are really like cutting edge and really can like again benefit you if something are found or not found, but also like benefit everybody else eventually, right?
Said, hi, Robin, what is the test called for cfDNA?
Yeah, so what do they call it? I'm trying, if you go, so for this one particular one, if you go and if you're interested in like learning more about it, if you actually look up CHARM, the CHARM Consortium, I'm trying to think what they actually call it. I mean, essentially it's just a blood test and they're looking for this specific cell-free DNA in the context of this trial. There are different labs and different research teams have come up with different what we call in the lab like assays to try and look for different biomarkers and that sort of thing. But if you actually look at the CHARM Consortium, like just like Google it, it's out of UHN, you'll find a ton of information there around what they're doing.
Thank you so much for the presentations. Do the signs, symptoms, and risk factors for pancreatic cancer recurrence differ from those of the initial diagnosis? If so, what should patients and caregivers be aware of?
So signs and symptoms probably wouldn't differ that much. It's still it's a matter of similar ones. Now, if the thing is, if it recurs outside of the pancreas, there may be some specific, depending on where it recurs, right? There might be some specific signs or symptoms, but really a lot of times what happens is it grows large, it causes pain because it's on other organs, like resting against other organs or nerves and that sort of thing. Or it causes like blockages in the GI because it's moving through your whole GI tract. The cancer may be spreading, and so it may cause blockages. So that's when you get like vomiting and things like that, and you can't eat and you start to lose your appetite and so on. So very, very similar. And the risk factors would be similar. What a recurrence sort of means, not what it means, that sounds funny, but a recurrence would be that basically when they went in and did a Whipple and did the chemo and so on, there was still tiny, tiny cells that were still there somewhere. And so then those start to grow again. So that's sort of what a recurrence is versus like we call them in sort of my world like a new primary cancer, which means a totally new cancer, or a recurrence, which means that from that initial cancer, not all the cells were killed or were taken out, and then it starts to grow again um, somewhere else nearby or somewhere far off because it made those little tiny cells that the surgeon couldn't see and the pathologist didn't detect because that there wasn't a lot of it, could go through your blood system and so on and then end up growing somewhere else. Yeah.
Okay, awesome. Yeah, that makes sense. Thank you so much for sharing your personal story. So that's great.
Yep.
Um, yeah, are there any other questions for Robin?
But it comes down to a whole lot of things, right? So it is stage, but let's say we're all stage 4, like we're talking about all stage 4 and you're diagnosed. So some people So first off, depending upon where you're diagnosed and where that happens, some some people may have better access to, again, some of the newer, more experimental therapies and get maybe put on a trial. And those experimental therapies may reduce the cancer or stop it from spreading. So people are starting to live longer. We see there's some trials out there with people who have the BRCA mutation in pancreas and sort of then treating them, and the cancer responds somewhat, but and so many people live longer. But this all comes down to so some people may die really quickly because like they have comorbidities, they're just not as healthy and things like that, right? And so the cancer is, impacts a certain part of their body, and that's what happens. Um, but also, so the living longer often comes down to subtype, so precision medicine. So even though we say pancreas cancer, all of those different gene mutations that we've identified, really, if you have a gene mutation in BRCA and you've got pancreatic, or you have a gene mutation in one of the Lynch syndrome genes or in TP53, the cancer is actually kind of different at a molecular level. And so some of the treatments that we might give um, might actually like be very effective for a certain subtype, but not another subtype. So some people it's not being effective at all. And sometimes it might harm you because it's making you sick and things like that. Whereas sometimes it does. And so more and more we try to subtype people. We try to say, well, we do genetic testing if you've been diagnosed, or we should do it. I shouldn't say it's not 100%, doesn't happen everywhere in our country. We have lots of inequities in terms of access to care and all that. But ideally, you would be, sequenced, your tumor would be sequenced. You'd actually understand the molecular profile of that tumor. So then you'd understand which treatments will probably work better and which won't work at all. But what happens if you go into and you start to get treatment, you might be a certain subtype that treatment you're getting in a clinical trial 10 years ago, overall, on average, people survive this much longer. But the thing is, that's an average. If you don't actually know the subtype, some people in that trial may have had a certain type of pancreas cancer due to a certain mutation. And this treatment is really good for that one. So those people, not the average anymore, those people are going to live longer. And then some people in the trial had a different mutation and that treatment didn't impact it at all. So overall, on average, it looks like this drug's effective, but if you actually drill down into knowledge that we know now, it's probably effective for some people, but not for other people. And so we need to get there in care. Like we start to know all of this from a research perspective, but the reality is at the end of the day, when someone shows up at a doctor's office and you're in a cancer center, we need to make sure that like the people there now have access to understand the profile of their tumor. I call it profiling, but like their tumor is put through, sequencing, and we understand it. So we give the person the best chance so we give the treatment that has the best chance of working well, right? And helping the person manage their cancer. Yeah. Does that make sense? I don't feel like I've explained it very well. And that's because in those trials of FOLFIRINOX or gemcitabine that had happened a while ago, we didn't have the knowledge that we know today to like subtype people often. So sometimes we go back to those trials, actually, not like if the data are available, and try to figure out whether there were certain subtypes and not and all that. Um, but like we just didn't know. So the average showed, let's say it improved survival by 6 months. I don't know, but like that's average. Some people would have been longer, some people it wouldn't have difference. Yeah.
I'd appreciate you referencing environmental/occupational exposure as potential risk factors, as do not see it typically mentioned. Trained as a chemist/science, scientist, I think all of the carcinogenic solvents, reagents, chemicals exposed to over the years.
Yeah. So there's a lot more work, thankfully, I think that's going on in environmental exposures and cancer. And yeah, there's a lot more. Hopefully we'll know a whole lot more like coming out and so on, because there are certain exposures that are really important. And then we need to learn more. Yeah. So I'm going to say, I wrote down life after Whipple. I'm probably not the best person to answer that, right? I don't know, Erin, like your nursing background and clinical background, and then if there are other folks who, had a Whipple and we talked earlier, Whipple surgery used to be like known as one of the worst surgeries out there. I'm just going to say one of the worst surgeries out there. Like when I was in my 20s, which was a long time ago, I actually talked to folks in the US and so on because of my some surgeons in Toronto in the US because of my past history, talking about should I get a prophylactic Whipple? Because my parents had died really young and everything like that. I didn't. I chose not to. In part, my partner at the time who was in medical school, and he's like, "You're not going to get a Whipple. Like Whipples are so bad." But that was a long time ago, and surgical techniques have improved, so much better than they used to be. And so I don't think it's quite the same as what you read about all the time, but it couldn't be for some people. Complications happen. But Erin, I don't know if you want to take that on because you sort of had that clinical background.
Yeah, definitely. So it's definitely a hard surgery, and just having spoken to a lot of patients that have had the procedure, I know that it is a big one, and a lot of the time you end up having to take enzymes after you get the surgery. Jane, I don't know if you would want to speak on your experience. Sorry to put you on the spot, no pressure. Just I know you've had the Whipple, and if I don't know if you could provide more. That is something I don't know.
I don't know the answer yet. No.
Said this may be completely, or sorry, this may not be completely related to the presentation itself, but one more question, if I may. As for chemo treatment, what's the higher priority adhering to the planned treatment schedule with potential dose adjustments, or prioritizing full dose administration, even if it results in treatment delays?
Yeah, this is, I'm going to explain myself. This is not a cop out though. To me, this is like a shared decision between you and your healthcare team. But I actually think it's really important to talk about. And so I know there is research. I can't come to a trial right now that I think in pancreas, but I know there's a lot of stuff in endometrial and ovarian cancer and in other cancers where lower doses, um, people do just as well. And so it's often also around trial design. So our doses are based upon the trials, what was put into a trial. That doesn't always necessarily mean that's the optimal dose. That's the dose that was decided on for that trial for reasons. Like it wasn't just picked out of the air, like for reasons. But that doesn't mean, and again, in trials, we're looking for this average effect size. So that doesn't mean it's the best dose for you. And so I don't like, I was actually in a conversation, again, this was around with like around ovarian and endometrial cancer and so on a few months ago, where they were talking about dose reductions. And to me, from a patient perspective or a family perspective, I feel like if I were getting treatment and someone talked about dose reductions, it might make me a bit anxious because I'm like, I don't want to, but it's not about dose reduction. It's about dose optimization. And so dose adjustments are not necessarily a bad thing. There's more and more research being done now in trials that are optimizing dose throughout, and people do just as well. And people do just as well on a little bit of a lower dose than this higher dose. And so I think it's a really important conversation to have, especially if you're having big side effects from a higher dose. I don't think we need to change the thinking that, oh, it's not going to be as effective, because actually we don't have evidence to say that. And some evidence says it in and there may be some in pancreas. I can look, I just don't know, but I know there are some in other cancers that show it's just as effective. And um, and you got to think. So I'm not trying to say I'm not saying anything bad about industry. We need industry because they're the ones developing these drugs. Like there's nothing about that. But they're also wanting to show these drugs are effective. So they're maybe providing a dose that's at a certain level to try and make sure. And that's not a bad thing because we do need, but sorry, I'm trying to be, a little diplomatic here, but I think it's a really important conversation to have with your care team. And I don't think you should feel, or anybody should feel anxious about any sort of dose adjustments, because really that could be just optimizing a dose for you, right? Yeah.
Definitely. That's a really good point. Because that's definitely something we hear a lot too, is that really scares people.
I think it does. And so it's not, certainly I'm not a medical doctor again, but it is a really important conversation, I think, to have with your healthcare team. Yeah.
Definitely, definitely.
Can I just step in? One of the things that's happened in the surgical world around some of these complex surgeries, and Whipple is one of them, and there's some others as well. Like we've realized over the last decade or more that the outcomes, the surgical technique and the sort of outcomes are better when we train, when people are subspecialized, but when people have a big volume. So surgeons do a lot of them over and over and over. And so our health systems have redesigned across our provinces and so on to really make sure that the people who do these surgeries, Whipple, are who do them all the time. They have high volume, they know what they're doing, they can be much more precise, they're practiced, they're skilled. And that might sound like intuitive and of course, that's the way it should be. But 20 years ago, that wasn't necessarily the way it should be. You would have people who didn't do as many. Maybe they just did a few a year, and it's not like that anymore. So the surgeries, I think, are just by that nature as well. People are doing them so often, they're getting better.
That's such a good point. That's definitely, and definitely, ask your surgeon how many of these do you do a year, and find out that kind of
Oh, I
thing.
would. I'm just saying right now, as anybody, again, I have the family history and so on. If I were diagnosed, I got lots of wonderful surgical colleagues, but I would be figuring out how many they did a year.
Totally,
Volume matters. Yeah.
definitely. Such a good point. You said I was fortunate to have an excellent outcome so far after Whipple and chemo. Oops, sorry, the chat just moved on me. There we go. I had my surgery October 2023, and I had no dietary restrictions or need to take Creon. So that's great. Sharing your personal experience and journey, Robin, in reference to geographic prevalence. I have to look at the map again, but any thoughts on pancreas cancer being diagnosed more and more developed countries, mainly because of more advanced medical systems? Appreciate all the pancreas cancer thrivers here sharing their journeys as well.
Yeah, probably. Oh, sorry.
Yeah, it's a Zoom. I'll put the link in the chat right now. But I don't know.
Yeah, I was just going to go back to question. Great question. Yes. So the deal is with a lot of cancers, both in more developed countries, we have more advanced technologies that people have access to. And so and so you can get an MRI or you can get a scan and see, and see that and be diagnosed. And in other countries, less advanced, we don't have maybe the same access. And so people die without knowing what they have had, right? And so I think there is some of that. We see that in some other cancers. We just have better technology. And so sort of some of the increase in incidence is probably access to better technology. And so we're spotting those cancers that we wouldn't see, that we might not see in other countries. The other part around it is data. And I know that might sound funny, but when we look at prevalence of different cancers. Like we need to go to cancer registries and we need to, have all of that data, and our data systems in more developed countries are much better. I mean, those data may not be collected in other countries. And so again, we just don't know about the incidence or the fact that someone maybe has died, right, of pancreas cancer, because we don't have the same sort of data infrastructure and data systems to monitor over time, which might sound like a very boring thing, but really, really important. I do population cancer research. So I want to understand what's happening at our community and our population level so we can prevent or reduce cancer. And if we don't know, then can't really do very much, right? Yes. So we do get, so the way two things on there, I think. One is just when it comes back to data and statistics, I work with these data sort of all the time. So um, the cancer registry here in Nova Scotia, but right across the country, they're all sort of mandated by law. They go back decades and decades. And so every cancer has to be registered. Like we need to know about every cancer that's been diagnosed. So it's registered in this registry, and we get all kinds of information like the stage, the histology, the grade, and all of that. What happens is that on a regular basis, Vital Statistics sends a file to that registry if there have been cancer-related deaths, and they match it up so that they know someone has died. So there's a really good system in Canada to be able to match like death files, I guess, through Vital Statistics with that doesn't mean we're not missing some people, particularly if people move away or outside of the country and so on, but there's actually a good system to sort of know if people have died of their cancer. But that's not information like your physician wouldn't know that. That wouldn't go to your physician and the care team. Like if you no longer had a relationship, they would have no idea. But in the back end, in our cancer registries, which is where I often, for my research, I'll get data from the cancer registries to understand this, so they know. I will say though, I would never know just as an aside, when I do research, I don't get identifiable information, so I would never know of certain like specific people, right? But I'm able to look at that, and so that's how we're able to look at these surveillance statistics to understand the death rates, incidence rates, and death rates. So that's sort of from the data side, but that doesn't go back to your physician necessarily, like at all. Like those data wouldn't. Your physician would have to figure it out through some other way, like which is odd, right? Like that data it wouldn't be information that would be transmitted back to your care team. But then when it comes to follow up, I think like for anybody, so I do a lot of work in like post-treatment care and look at like care after someone's sort of had a cancer, been treated, and there's no evidence of disease right now. And I think from yourself, to speak to your team, if you're going to be discharged, I think it's really important for you to have very clear information. And Jane, you probably do, but what to look out for, what to expect, what to look out for, who to call if you're anxious, if something happens and you're not sure, and so on. But also somebody should be following you. So usually that's a family doctor, a primary care team that's following you, but they also need information. And so I think just as a piece of advice, sort of just to make sure your oncologist sent like that, there's good information sent back to your primary care provider. That's all. So they know what to do. They know what to look out for. They know what to do. You know what to look out for. You know what to do. And both of you know what to do if something happens and you need to get back into, let's say, the cancer system or back into like diagnostic testing quicker or something like that. So I think those are the parts that you just want to make sure everybody knows, because I don't know, and everybody on here has a lot of experience interacting with the health system. And I said to someone this week, I say it to my students regularly, I say it to my kids. It shocks me that how many years ago now, 60 years ago, we could put somebody on the moon and we still can't figure out how to communicate information to people. Like it just It just boggles my mind. And so I think that for being discharged, I wouldn't be like overly anxious or anything. You need information. You need to know, okay, what do I look out for? What would be concerning? Your family doctor needs to know that as well. And then, yeah, yeah, need the
Yeah.
information. Like,
Yeah.
and you need just the clarity. Like everybody needs the clarity. That might sound funny to say, but you, your family, but also your family doctor and your team, like everybody just needs to be clear with the information. And then,
Yeah.
and that's actually, again, that's why I sort of said about somebody on the moon, but that's often where things fall down, right? People aren't clear and things weren't communicated. And then, yeah.
Are there any other questions for Robin? Hey. All right. Well, Robin, thank you so much. This was such a great presentation and a lot of really good insight and a lot of great answers. And I always think it's so fascinating when you can bring personal experience and sort of professional experience and sort of bring them together. I think that was really, really impactful. So thank you so much for being here today and for taking time on your Saturday afternoon. We really appreciate it.
That's okay. And my kids didn't even come in, so that's all right.
Amazing.
No, it was a pleasure to be here. Thanks, everyone. And for real, like you can take my email or, Aaron can give it to you if anybody wanted to reach out. That's not a problem. Yeah.
That's so amazing. Thank you. And for everyone as well, the quiz will be coming around as soon as we're done here. I will send that off. Just remember that if you are interested in being eligible for one of the Craig's Cause sweaters, you just need to complete the quizzes for each module. And then we'll send you a sweater at the very end after the 10th module. So please do fill that out. It'll be coming around. If you have any questions about the quiz, please let me know. I'm happy to help with any of that. And otherwise, thank you everybody so much for being here today. It was so great having everyone and lots of really great conversation. And hope everyone enjoys the rest of your weekend.